Hey Insta family, it's Dr. T here. Tuesday night, rapid fire Q&A. How are you guys? I missed you guys last week. I was on a plane that was coming in like this to land. I was over in Sydney at the Fertility Society of Australia and New Zealand conference. First opportunity that we've had to catch up with each other in 2 years, and it was fabulous. Actually, it was probably 2.5 years. So it was absolutely fabulous to catch up with everybody. But it's lovely to be back with you guys. I hope you're good. So I'm sad. I'm sad today because one of my inspirational people in my life lost her life today, Olivia Newton-John, and I remember. So if you've got Olivia Newton-John moments, I want you to drop them in the comments, because I remember dancing around my parents' lounge room with the vinyl spinning on the turntable and banging out Physical and Hopelessly Devoted to You. And yeah, so if anyone else has any Olivia Newton-John moments of their life, I made up the most craziest dances with my best girlfriend to all the Olivia Newton-John. We all wanted to be Olivia Newton-John when we were little kids. So yeah, I've had a bit of a sad day today. But celebrating an amazing and powerful woman. And look at that. Yet another amazing and powerful woman in the world who has done good with her challenges in life. And, you know, if it teaches us anything, is sometimes we're faced with challenges in life that actually help us to create goodness for other people in life. And so that's something that she certainly did with all of her challenges, where she turned them around and created goodness for other people. And I just think that's an amazing characteristic. So if that's you, think about the things that you might have had that are challenges in your life and how you can turn them around to create goodness for others. But on a more, academic note, does anyone have any questions? I've got a couple. What are we? 7:36. So just a reminder to anyone else who's new to our Tuesday night rapid fire. You can look at my Jenga in the background. That's our cushions from our outdoor. It's pouring rain and cold here in Perth, and so everything's been bundled inside. But anyway, back to the topic. So rapid fire Q&A. Rules of engagement. We want questions that are not your life story. Very straight, simple questions. I will be giving straight and simple answers. I try to keep it to a sentence, but as many of you know, I very rarely keep it to just one sentence. But I will try very hard to make the answers generic. Please ask anything, any burning question, because no doubt there will be somebody else on here who will really benefit from hearing the answer, and maybe they've just, a bit too nervous to ask the question. So please drop any questions in here, and don't forget to just tag anyone and share this with as many people as you can. You know, my mission is to just empower and inspire and educate as much as I can, and just help you guys through this whole reproductive and fertility journey. So I've got a couple of questions. There's some, I can see some beautiful. Stanley Wall, how are you, my friend? Lovely to see you on tonight. You are surrounded by lots of women, but it's good to see you on it. And there are lots of lovely people that I have seen join, so welcome, welcome. So one question that I have been asked is, does endometriosis cause miscarriage? Well, in a very short answer, yes, but it can increase the risk of miscarriage. But I just want to explain endometriosis. So endo, as you may or may not know, is the growth of the lining of the womb outside the womb. And the most common place we see it is in the pelvis. So all of your pelvis is covered by something called peritoneum, and it's kind of like glad wrap covering all the organs of the pelvis. And often endometriosis will kind of lodge itself into this glad wrap, and it's fed by estrogen. So every time you have an ovulatory cycle, any time you're taking any hormones that increase estrogen, taking any exogenous external hormones that are estrogen, it will make this stuff grow. And every time the lining bleeds, this stuff bleeds as well. And that blood in the pelvis can create pain. It can create scar tissue, which then makes organs stick together, so it can distort the tubes and the ovaries, making it difficult for an egg to be released or an egg to reach the tube. It can cause blockage of the tubes, but it can also cause massive inflammation. It releases all of these chemicals, the kind of pro-inflammatory chemicals, making the whole environment really hostile and hostile for embryos to implant. We also know that the lining of a woman with endometriosis is probably not normal. And that's probably part of the reason why their immune system is unable to recognize that the endometriosis is in a foreign place and get rid of it. So there's probably something inherently wrong with the lining of a woman who has endometriosis. And so we know recurrent implantation failure, so when the lining the lining is presented with an embryo, the embryos don't stick. So we might produce all these beautiful embryos and we might put them back into the lining, but they just don't conceive. And, the evidence shows us that if a woman has endometriosis, this one, and a woman might be infertile for another reason, let's call it a male factor reason, and they both go through IVF, the pregnancy rates in a woman with endo will be lower. So their fertility journey is often longer and they're having more treatment than a woman who might be infertile for other reasons requiring fertility treatment. So it's a really long-winded answer, but yes, we do know that miscarriages can occur in the context of endometriosis, and I would strongly recommend that you talk to a fertility specialist who understands endo and can really drill down into your particular case and whether medical treatment or surgical treatment is the best for you. But yes, simple answer is yes, it can be associated with miscarriage. I can see some questions coming through, so I'm going to, because I've got a funny feeling I might have answered the last one last time, so I'm going to go to these questions here. Alex Peterson, will a double embryo transfer have success if you have had failed transfers? Will it have success? Well, I'm going to say it could have success. There are studies that show that a double embryo transfer will slightly increase your chances of a positive pregnancy test. It will significantly increase your chances of having a multiple pregnancy, and along with multiple pregnancies comes an increased risk of miscarriage, an increased risk of preterm birth, cesarean delivery, time in the nursery for your baby, cerebral palsy rates, so on and so forth. So you've really got to weigh up, is doing a double embryo transfer, is it the right time? Have you undergone enough transfers to really warrant that? Are there other things that you could be looking at, the things I've just talked about, that could be causing recurrent implantation failure? There is a study that looked at people who had a double embryo transfer versus people who had recurrent transfers, what we call cumulative pregnancy rate over a number of transfers. And the pregnancy rates there over a number of transfers is actually no different to if you transferred to once. So, there's some question as to what you're actually measuring, to pregnancies cumulatively or pregnancies in one transfer, but certainly that is something that I'll often discuss with patients if I think it is timely to talk about double embryo transfer. But would I be doing a double embryo transfer preferentially? Would I be doing it after one or two transfers? No way, because the risks of multiple is significant, and you'd really have to be having a good hard discussion with me to get a double embryo transfer. We have some of the best single embryo transfer rates in the world. We have the lowest incidence of multiple pregnancies in the world, and we're really proud of that. So, it's not our preferred, in Australia and New Zealand, not our preferred way of doing things. Oh, I'm sure there were other questions. Any other questions? Well, somebody else asked me a question last time. I think I answered it, but I'll go and answer it again, about diminished ovarian reserve and taking DHEA. In fact, now that I think about it, I did answer it, but I'll answer it again. So there are women, okay, let me take this back a step. As we age, our egg numbers decrease. That is the biological pathway. So age challenges our quality of eggs because they've been around for a long time, and it challenges our quantity because we're losing them. In fact, we're losing them from the moment we're born, before we even have our first period. So we do know that our ovarian reserve, what we've got left in our ovaries, diminishes with time. So if someone has a low ovarian reserve, in some cases, I might expect that. So I might expect a 40-year-old woman to have a low ovarian reserve, that it's expected. But then there is a diminished ovarian reserve that is unexpected. So perhaps a 32-year-old who has a low ovarian reserve for her age. So true diminished ovarian reserve, unexpected. And I suppose the question is the role of DHEA to try and improve that ovarian reserve, or is the role of DHEA to improve the quality of the eggs that are remaining? And my feeling sits with the second, because biologically eggs are sort of sit in a pool of androgens. They're the substrates that then create estrogen, which is produced by the follicles. And so the idea of DHEA is to kind of provide the substrate to be able to create more estrogen and to provide a better environment in which that little egg is being, I guess, cooked or germinated within the follicle. And so to me, the role of DHEA is in someone who is much older, to try and improve the environment of follicles that are also going through that aging process. The role of DHEA probably isn't in the younger egg, and it probably isn't to increase egg number, but rather to help improve the viability of those eggs in a much older woman who is challenged by age. So a quality and a quantity issue. I do know a lot of the research out of, I think it was predominantly New York, did show an increase in recruitment of numbers, but the population being studied was much older. So I think it's really important to understand who could be considered for DHEA, and that there isn't great quality evidence, and it's really important to sit down and talk with your fertility specialist. This particular person was quite concerned about the side effects, and there are side effects. It is a mild androgen. And so oily skin, maybe some spots, maybe a little bit of hair growth here and there. The major risks of androgens, so deepening of the voice, sort of sit more with testosterone, that really powerful androgen, than it does with DHEA. But it is still a recognised side effect. So it is really important that you are completely informed in your case about whether it's a suitable treatment for you and what the side effect profiles are before you just pop some DHEA. So hopefully that's helpful. Hey guys, are there any more questions? I feel like I've just rambled on tonight. Has anyone else got any questions? Talked about double embryo transfers. Oh, here they are. Alicia. Does egg harvesting reduce your chance of having a natural pregnancy? No way. All we do when we harvest eggs, I'm assuming you're talking about elective oocyte cryopreservation. All we're doing is we're just collecting those that you would have lost anyway, because every month you're actually producing a cohort of eggs, one of which you ovulate off and the others just die. So we're just collecting the ones that you would have lost in that month anyway. So it doesn't reduce your chances of having a natural pregnancy anyway. So there you go. That's why it's such a good option for women who want to have reproductive options in their future. All right. I would, again, go and talk to a doctor about your individualised situation, though, to see if it's appropriate. Cara, any natural ways, food or subs, to try and regulate cycle with PCOS? Yeah, the mainstay of PCOS management is lifestyle. So it is diet and exercise, really reducing that underlying high level of insulin and sort of glucose intolerance. So really watching weight management, really watching the types of foods that you're putting in your mouth. You know, you don't want to be having a lot of processed or simple carbohydrates, and doing regular exercise to kind of mop up all of those extra sugars that you get in your diet just by eating carbohydrates, which, you know, make up the majority of our diet. I would strongly recommend that you have a chat with a fertility dietitian who can design sort of specific eating plans around PCOS. But yeah, absolutely. As far as supplements go, I mean, one of the mainstays we use in treatment is metformin. There is a supplement out there on the market called myo-inositol, which is thought to do the same as an insulin sensitizer. There hasn't been a lot of work done in the fertility space. It biologically makes sense, but it's certainly not something that I would prescribe. People do take it instead of metformin because the side effects of metformin, gut upset, you tend not to see with myo-inositol. So they're probably the things that I would recommend first line. Cami182, is there a length of time you should wait between egg collections? Oh, that's such an interesting question. I guess it depends on why you're having an egg collection. If you're having it for cancer, just get in there and collect as many as you can, as many times as you can, as many times as Medicare will allow you to, I guess, is one thought. If you're doing it for elective oocyte cryopreservation, or even for an IVF cycle, generally speaking, we will do a cycle which falls within your natural menstrual cycle, and then we'll give you a month off because those big swollen ovaries need some time to settle down before we then try to stimulate them again. So I don't know of any centre in Australia, maybe overseas, but I don't think there would be very many people that would do back-to-back cycles. It's just, apart from being completely burdensome for you, it probably wouldn't be as effective. But there are certain populations who do repeated collections, and that would generally be in the context of oncofertility or fertility preservation, where there's a time limit before chemotherapy treatment. That's a whole nother ballgame. Oh, here are all the questions. Here they come. LCD Mario. I don't know the question. Can melatonin increase progesterone levels? No, works completely differently. Melatonin is essentially it's essentially from the pineal gland, which helps you regulate diurnal time variation. So we often use it as a jet lag drug, but it actually also acts as a really powerful antioxidant. So it's not used to treat progesterone levels. It's more, the idea behind it is to try and improve egg quality in older women. Again, not a lot of research. Mum in the making, good to see you. Is it okay to take melatonin in the lead up to an FET? Yes, but you got to think about why you're taking it. If you're taking it to help you sleep, fair enough. But if you're taking it to improve your eggs, well, you're putting back an embryo. So I guess, well, I suppose you're taking it to help those eggs that might be germinating and released in future months. But it is safe to be taking up until such time as you put an embryo in. There's lots of melatonin questions. Can melatonin and DHEAS, there's your question now. Can melatonin and DHE increase progesterone levels? No. I answered it the same. Ellie Claire, Hashimoto's. Anything else besides prednisolone and clexone at transfer? Well, Hashimoto's is a thyroid disorder. I wouldn't really be treating a thyroid disorder with prednisolone and clexone. Have a chat to your doctor. Hashimoto's is an underactive thyroid. So the thyroid gland, which is your main gland of metabolism, is not working very well due to an autoimmune condition. And we need to be providing you with enough thyroid hormone to reduce the chances of pregnancy complications. So generally speaking, it's about actually giving you thyroid hormone or thyroxine or Utracig. You might have heard of all of those, because the gland itself is not doing its job due to autoimmune conditions. Prednisolone and clexane are not used to treat that. But have a chat to your fertility doctor about that. Okay, I'm going to wrap it up very soon. There are 3 more questions. Sarah, what causes low sperm count? Loaded question, Sarah. Lots of things. Obstruction, early ejaculation, ejaculating and then giving me a sample. Half of it's there. Low testosterone levels. Testicular failures. Okay, let me just try and categorize this a bit better because I'm kind of being a bit scattery. So the problem either is with the stimulation to the testis. So something's not stimulating, and it could be due to a mass in the brain or a high prolactin for some reason, or it's that the testes themselves are not working anymore. Maybe there's a mass in there, or the pipes going out are blocked. So, for example, a man who's had a vasectomy will have a 0 sperm count, even though he's producing sperm because the sperm can't get out. So, we always, when a man has a low sperm count, the number one thing, do it again. Ask him if he missed the pot. Assess all of those things, the context in which the sperm sample was given, and then examine the hormones from the brain, and then examine the hormones from the testis. Physically examine the man if it's appropriate, but definitely look at doing a testicular ultrasound. So these are all the things that we do to assess why the sperm count is low. Now, also remember that you really need to have at least 2 low on different occasions to prove that we've actually got an ongoing problem. Great question. What do you feel is this egg quality in older women? You know what? This, Vanessa, is the golden chalice. You know, if we knew exactly how to improve egg quality in older women, we would bottle it up and we would be giving it to every woman. But the reality is the research around this stuff is ongoing, and there's no fantastic studies. Otherwise, we'd all be doing it. So we've talked about things like DHEA, we've talked about androgens, generally we've talked about melatonin, we've talked about CoQ10, all these things are kind of done. The latest stuff is people injecting protein-rich plasma into the ovary to kind of rejuvenate it. Again, really, really early days as to whether or not it's safe and even whether or not it's actually harmful. So it's really hard to say, my friend. I can't put my hand on my heart and say conclusively that we have found the absolute answer to that question, and there's research going on all around the world to try and rejuvenate eggs for women. But biologically, we really should have all been reproducing in our 20s, and that's the honest truth. Unfortunately, society, for most of us, including me, just didn't set it up that way. All right. Okay. I think I'm going to wrap it up. I think I'm done. I think I'm emotionally depleted today. I don't know about you guys, but I have found it a really emotional day. I am going to go and have my glass of sparkling water because I'm not drinking, and celebrate the life of a truly powerful and magnificent woman. And, you know, if we can all just learn one thing, it's to be kind and to be grateful and just to think about ways that you can enhance the lives of others. Thank you so much for jumping on tonight. It's been great. So many questions. Keep them coming. I hope to see you next Tuesday. Stay safe, stay well, and I'll see you on the other side. Bye.